Good morning, my name is Aurora Mercado, and today we're going to continue with our English sessions. Particularly, we're going to talk about testicular tumors, and today's advising teacher will be Dr. Matías Salinas Chapa. First of all, we're going to talk about a brief review of the testicular anatomy. The testicular parenchyma consists almost entirely of seminiferous tubules enclosed by a fibrous tunica albuginea, which extends as septation between lobules and of testicular tissue, dividing the testis into several of 100 lobules. The seminiferous tubules will merge then centrally to form the erected testis, from which efferent tubules will perforate the tunica albuginea and convey the seminal fluid to the epididymis, which is a tubular structure posterior to the testis and is divided by the head, body, and tail. And the epididymis is a single duct that will then become the vasa deferens and will continue to the spermatic artery. Now about the vascular supply and drainage of the testicles. Each testicular artery will arise directly from the aorta, below the origin of the renal arteries. And se trabó. Okay. As introduction, testicular neoplasms account to 2% of the malignant neoplasms in men, being the most common non-hematologic malignancy in men from 15 to 49-year-old age group. Talking about more about the testicular tumors, the risk factors for testicular cancer will include testicular maldescension, family history. It's been said that first degrees relative with testicular carcinoma increases the risk by 6 times. Infertility is another of the risk factors, and previous history of testicular tumor will increase also to 20 times the risk for developing testicular cancer. The typical clinical presentation of these cancers will be a painless enlargement of the testis, a palpable nodule, and acute pain that may mimic an infection or inflammatory disease. So this will cause that initially may be misdiagnosed and having epididymorchitis. Some patients, up to 14% of them, will present with symptoms of metastatic disease, such as constitutional symptoms as back pain, abdominal mass, lymphadenopathy, or weight loss. So as radiologists, what is our work here? We have a very important role in identifying the primary tumor, accurately staging the disease, and conducting the follow-up imaging and surveillance of the tumor. The ultrasonography is the primary imaging modality for a suspected testicular neoplasm. We'll use a high-frequency transducer, and it will help us distinguish between intratesticular masses, which are more commonly malignant, and extratesticular masses which are almost certainly benign, with the accepted prevalence of malignancy up to 6% of the cases. Tumors larger than 1.6 centimeters that will show increased vascularity with color Doppler. However, color Doppler findings do not appear to be very important in the evaluation of testicular tumors, but it may help to identify tumors that are isoechoic with the testicular parenchyma. And although ultrasound cannot be reliable, usually used to accurately predict the tumor histology of the tumors, some generalization can be made, such as the seminomas, which may present as hypoechoic, homogeneous, and they usually not have calcification or cystic spaces in them. The counterpart would be the nonseminomatous germ cell tumors, which normally will present as a heterogeneous ecotexture and they will have cystic spaces or calcifications in them. For starters, of one of the lesions of relevance of the testicles will be the microlithiasis, which are calcifications in the seminiferous tubules, and they usually are so small that they do not produce posterior shadowing, and they have two kinds of presentations that will be diffuse and limited. The diffuse form will present as innumerable small hyperechoic foci, and they will be diffusely scattered, and they will be tiny, 1 to 3 millimeters, and they will rarely shadow. As already said, they are really very small. So, and the limited form, they will present as less than 5 hyperechoic per image. By ultrasound, and we will see multiple small echogenic foci with no posterior shadowing. The contribution of microlithiasis of the testicles to the risk of malignancy has been controversial. However, more recent information has shown that the presence of this on an otherwise normal testicular ultrasound does not predispose the patient to testicular malignancy. So, with that being said, the presence or absence of testicular microlithiasis is not significantly associated with the risk of malignancy. To continue with the testicular tumors, we'll have a lot of histologic subtypes of testicular tumors. There's a accepted classification that divides them into germ cell tumors, sex-cord stromal tumors, and miscellaneous tumors. It is of primary importance to make a distinction between two basic tumor types, which are the germ cell tumors that also divide into seminomas and non-seminomatous germ cell tumors. Why is this division important for us? Because it plays a critical role in determining the approach of treatment of these patients. As we know, seminomas are more radiosensitive and carry a better prognosis with approximately 90% survival rate. And the non-seminomatous germ cell tumors are less radiosensitive, but are usually treated with surgery and chemotherapy. For starters, we are going to talk about the most common pure cell tumor, which is seminoma, and it is also the most common tumor type in cryptophagoid testis. And they will have a peak incidence in the 4th and 5th decade, and they rarely occur before puberty, and they are mostly unilateral, and the contralateral tumor will develop eventually in 8% of the patients, which is a very low rate. And it will have the most favorable prognosis of the malignant testicular tumors, as I already said, and they will have a really good response to radiotherapy. And they have two kinds. The classic form, that is 80% of the cases, will be a homogeneous, solid, firm, and round or oval mass, and the spermacetic form that will present as a multinodular, fleshy, gelatinous, and hemorrhagic tumor. And on the images of the right, we'll have a seminoma occupying most of the testis, and in the typical appearance of this tumor as a homogeneous hypoechoic sonographic appearance, and histopathology confirmed to be a seminoma. By ultrasound, the characteristics that we're going to see in these tumors will be a solid mass, well-defined, hypoechoic without calcification or tunica invasion, And cystic changes as a result of necrosis or hemorrhage. And as I already said at the beginning of the presentation, ultrasound will be the first technique to evaluate these tumors, and the CT or MRA will be used for metastatic staging. And on the image on the right, we have an ultrasound of a 27-year-old man that shows a typical appearance of a seminoma, which is a homogeneous hypoechoic mass that replaces and enlarges the right testis. And the tunica was intact despite the size of this mass. Orchiectomy confirmed to be a pure seminoma. Okay, so we have our first case, one of my partners.
Case 1, 28-year-old male with a painless enlargement of the right testis. We have two images of grayscale ultrasound, where we can see an ovoid well circumscribed. Okay, two images of grayscale ultrasound of the testis, where we can see we can see an ovoid mass. Okay, which is well circumscribed, hypoechoic, homogeneous. It's solid, and this intratesticular. With these findings and the clinical scenario, our first diagnostic should be a testicular tumor, which the most common and this age, 28, and with these characteristics should be a seminoma, but only with ultrasound we cannot do an histologic diagnosis. The next step should be to do an orchiectomy to make the correct diagnosis.
That's right. This tumor was revealed to be a seminoma. Okay. To continue with the nonseminomatous germs and tumors, these tumors are more aggressive than seminomas, and approximately 1/3 of these patients will have metastases at the time of presentation. They have a peak incidence between the 2 and 3rd decade, and these tumors occur more often in younger patients than do seminomas, and they are very uncommon in puberty and after the age of 50. 70% of these tumors will produce hormonal markers, and